Hello, today I'm going to explain to you the systemic modifying factors. I hope my voice is clearly and you can understand and hear me clearly. Um, we have 8 factors that lead to periodontitis. These are hematological diseases, hormonal disturbances, drug-induced disorders, genetic, nutritional, psychomatic, age, and smoking. So these all 8 factors, they lead to gingivitis and periodontitis. Let's start. So with the hematological diseases leading to periodontitis. We can divide the hematological diseases in 2 categories. One, the first group is that alters the numbers of leukocytes. And the second one is we have altered neutrophil function. So the first one is talks about the numbers, and the second one talks about the function. And we have here at first the leukemia. The leukemia is the first type of hematological diseases. It is acute and has short duration. It is a malignant neoplasm which affects the bone marrow, which releases then immature white blood cells. And these immature white blood cells infiltrates all organs. So regarding dentistry now, it leads to gingival enlargement due to infiltration of the immature white blood cells. Then local factors come and release a secondary inflammatory response. We have acid bone resorption due to infiltration, and the periodontal ligaments will destruct. So till now we have due to infiltration, we have the gingival enlargement and the bone resorption. Third, we have also there is another consequence of leukemia. We have gingival bleeding. Gingival bleeding. Why do we have gingival bleeding? In the exam, the doctor, the dentist, or the professor can ask you, give me a reason why gingival bleeding happens in leukemia. The bone marrow is replaced with immature leukemic cells, and these immature leukemic cells reduces the production of red blood cells and platelets. This then leads to anemia and thrombocytopenia, which increases the bleeding tendency. Okay, so this is the first one. I have talked about the acute one, about the acute leukemia, but we have also chronic leukemia. In chronic leukemia, gingival enlargement is uncommon. This is what you have to know. So when in the exam they talk about gingival enlargement, leukemia, so you have to know, okay, it is the acute type of leukemia. So then we go to neutropenia. Neutropenia means we have a decreased number of neutrophils. There are 2 types, agranulocytosis and cyclic neutropenia. Agranulocytosis means we have a complete absence of neutrophils, and cyclic neutropenia means we have an incomplete absence of neutrophils. Okay, let's take it here. Neutrophils. Okay. Then what we have here is it is the agranulocytosis. We have a complete absence. We have no neutrophils. That means it is we are easily infected. We have full odor, and we have many reasons. But these are like to have a quick imagination, a quick understanding what agranulocytosis is. It is we are easily infected. The difference to cyclic neutropenia is that we have cyclic episodes. Every 21 days, we have cyclic neutropenia for 3 to 5 days. These will have hematological diseases. Not everyone, I said we, sorry, I mean like those who are affected by cyclic neutropenia have 3 to 5 days every 21 days cyclic neutropenia. That means we have also here gingivitis and periodontitis. It is a cyclic one, it's cyclic episodes. It goes and comes again. So then C, we have AIDS. Till now we're done with the 2 types of hematological diseases that alters the numbers of leukocytes. Now we go to the second category. It is we have altered neutrophil functions. So the third one is AIDS, and we have here a virus that alters the T lymphocytes. This leads to HIV gingivitis and HIV periodontitis. The HIV periodontitis is also called necrotizing ulcerative periodontitis. It leads to necrosis and full odor. Okay, then we have the fourth type, lazy leukocyte syndrome. We have here a bone marrow which releases normal neutrophils, but as the name says, we have lazy leukocytes. That means that the neutrophils are lazy to do its action, chemotaxis. So they're only lazy to do chemotaxis, but the rest, phagocytosis, intracellular killing, extracellular, everything is normal, but their chemotaxis function is lazy. For fifth type, Shiraki-Higashi syndrome. Shiraki-Higashi syndrome is, you can imagine as a little young boy who has albinism, light hair, light color, light skin, and who has albinism due to defect in melanocytes, and it has defect in neutrophils, which means these patients are easily infected, and they have defect in platelets, so they have a tendency to bleed. Okay, so these are till now the 5 types of hematological diseases which leads to periodontitis without any local factors. So they directly affect the periodontium. Okay, then we go to the last one, stage 3, grade C, periodontitis. I don't know if you got this as a separate topic in periodontology, but this is a quite big topic to understand. But just to summarize it, here the incisors and molars are affected, and it leads to a vertical bone resorption. There's a difference between vertical and horizontal. The vertical is much better than the horizontal, as you can do bone graft in the vertical type and not in the horizontal type. An important point to know is we have no local factors for edentulous patients. So you never see gingival enlargement in edentulous patients due to not having any local factors. So the second type is now the hormonal disturbances. The hormonal disturbances is we have here the sex hormones, the diabetes mellitus, and the hyperparathyroidism. So the sex hormones. And regarding these hormones, we have four types, or 4 points we have to talk about: the pregnancy, puberty, menstruation, and contraceptive pills. Pregnancy. In pregnancy, we have increased progesterone and estrogen. This leads to increased gingival enlargement. So this parallel, increased estrogen and progesterone leads to increased gingival enlargement. Gingival inflammation, it is noticed between the 3rd and 8th month. Its peak is the 8th month, and these inflammation is called pregnancy tumors or epilis, and it is removed after after the woman give its birth to its baby. Second one is the puberty. The puberty is we have gingivitis due to hormonal imbalance. This can decrease in adulthood when the local factors are removed. Okay, menstruation with acid can also cause gingivitis. It can decrease after the end of menstruation if the local factors are also removed. And the contraceptive pills is with the time of increasing pills, taking pills, it increases the gingival inflammation after like a time of 1 year, 1.5 years, 1.5 years. But it can decrease when you stop taking the pills. So these four can lead to gingival inflammation, gingivitis. So what is the effect of progesterone actually on periodontal diseases? When we have increased progesterone, it leads to vasodilation. And this one affects the mast cells, which leads to degranulation. The first and secondary granules will be released, and then inflammatory mediators will do its function. So, and second, it affects cell-mediated lymphocytes. So two things, it affects mast cells and cell-mediated lymphocytes. This is like the effect of progesterone on periodontal diseases. Now regarding the prevotella intermedia, it actually uses progesterone and estrogen as growth factors, but like in pregnancy, they use progesterone and estrogen as growth factors instead of menadiene, what they actually use. Now what we have is the menopausal gingival stomatitis. The menopausal gingival stomatitis is when we have decreased estrogen, it leads to increased osteoclast. Okay? Till now we have talked about the sex hormones regarding the hormonal disturbances, which leads to periodontitis and gingivitis. Now, diabetes mellitus is important to understand. When it is uncontrolled, it leads to burning mouth and xerostomia. This what is important to know is the increased advanced glycation and products. I wrote and here plus and products, which are also called ages. So regarding these ages, we have here the receptor, the also called RAGE. This binds on neutrophil, blood vessel, collagen, and monocytes. This RAGE, when it binds, it leads to inflammatory cytokines release. Binds on blood vessels, leads to microangiopathy, which narrows the lumen capillaries, decreases the oxygen, and by then increases the anaerobic bacteria. It binds on collagen, which increases the collagenase and decreases the turnover of old collagen. Okay? It binds on monocytes and leads to the release of inflammatory cytokines. There are two types of diabetes, the type 1 and type 2. The type 1, the two important bacteria is the capnocytophagia and the AA. And the type 2 diabetes mellitus is the P. gingivalis and the P. intermedia. So, this is till now the diabetes mellitus. Regarding to hyperparathyroidism, what is hyperparathyroidism? It is an increased hormone of the parathyroid hormone. It leads to an increased bone remodeling with osteoclastic resorption. So we have here an osteoblastic and an osteoclastic resorption. We have an action of both. As we have an action of both, it leads to hypercalcemia. The calcium of the bone is released into the blood, and we have an increased calcium serum. And we also see in the X-ray brown nodules. It's also called as osteitis fibrosa cystica. Till now we're done with two types: the hematological diseases and the hormonal disturbances. Now we talk about the genetic disorders. The genetic disorders have the Papillon-Lefèvre syndrome, the leukocyte adhesion deficiency, and the Down syndrome, and the hypophosphatemia and the Ehlers-Danlos syndrome. We can also call as the elastic man. So, the Papillon-Lefèvre syndrome. It is a hyperkeratosis of the palm and the soles. Around 4 to 5 years, we see a complete loss of the primary teeth, and at the age of 10 to 15, we see a complete loss of the permanent teeth. Okay, we see here an impairment of neutrophils chemotaxis with antimicrobial activity, and an impairment of monocyte with decreased lymphocyte response. We have here a problem in the total white blood cell function, the total one. So we have neutrophils and monocytes and lymphocytes and like many of the types of white blood cells. Okay, and here, which bacteria is involved? It has the same bacteria as the stage 3 grade C periodontitis, the AA1. So Papillon-Lefèvre syndrome, and the stage 3 grade C periodontitis from the hematological diseases here have the same bacteria involved. Okay, so then what we have here is leukocyte adhesion deficiency, also called LAD, abbreviated as LAD. We have here a defect in the integrin CD18, and which is responsible for linking the neutrophils with the blood vessels. So we have no phagocytism. Don't confuse the leukocyte adhesion deficiency with the lazy leukocyte syndrome. The lazy leukocyte syndrome is lazy to do its function, chemotaxis, but the rest of its function is normal. Okay? In the leukocyte adhesion deficiency, the leukocyte, okay, the function of the neutrophil is normal, everything is normal, but we have a defect in the integrin CD18. So we have a linking problem here. Okay? And the other one, the function is lazy, the function, okay, there is a defect in the function. Here, we have a defect in the linking. Okay, the third type is the Down syndrome. Down syndrome is a trisomy of the chromosome 21. It decreases, we have a decreased immunoglobulin A, which is responsible for the mucosal immunity and the saliva. We have a decreased T and B cells, decreased PMN chemotaxis function. Okay, I summarized the points of every deficiency and syndrome, so you can have so we can have an idea about the different types of diseases that affects periodontitis or the periodontal ligament. Okay, then what we have here is the hypophosphatemia. The hypophosphatemia, as the name says, we have a decreased alkaline phosphatase, and this leads to decreased bone mineralization. We have skeletal deformities, we have waddling gait, we have a short stature, and the dental phenotype is we have the odontohypophosphatasia. Odontohypophosphatasia means we have a defect in the cementum, the acellular type and the cellular type. Okay, so when we have a defect in the cementum, the Sharpei fibers, they can't bind to the defect cementum, so we have a tooth loss. You have to know that we have a normal dentine, but we have abnormal cementum here. So due to the decreased mineralization, is that we have a weak bone anchorage between the tooth and the alveolar bone. Okay, due to the defect in the cementum. So then the last type is the Ehlers-Danlos syndrome. The Ehlers-Danlos syndrome is also called elastic man. We have here an increased collagen fibers. Increased collagen fibers leads to hypermobility of the joints and skins. The type 8 is the most important one. We have here many points. I just wrote the 8 one here as we forgot. Here the type 8 is the most important one. There are many types, but for the dentistry, like dental school, they concentrate. I think at my university they concentrate on the type 8 Ehlers-Danlos syndrome. Precautions. What precautions do we have here is we have here the inferior alveolar nerve block. When we do it, it leads to hematoma, and we have to give only light orthodontic forces. Okay, because many people confuse between these two. The Ehlers-Danlos syndrome, the increased collagen fibers, this turns to elasticism, while in scleroderma we have as an increase of collagen fibers leads or turns to sclerosis. So we have here an elastic man, but we have here a stiff man. Okay, elastic man, and we have here a stiff man. Okay, so the fourth type is the drug reaction. They do gingival enlargement. The three most important types is the dilantine, also called phenytoin, nifedipine, and cyclosporine or sandimor. So the first type is responsible for the epilepsy, and we see gingival enlargement in 60% of the patients. Nifedipine is for cardiovascular diseases. 20% of the patients do get gingival enlargement, and we have the cyclosporine or sandimor, which leads to immunosuppression. 25% of the patients are affected of gingival enlargement. Only in the cyclosporine we have a positive correlation between the dose and gingival enlargement. So when we increase the dose, the gingival enlargement increases. When it decreases, this decreases also. And the dilantine and nifedipine, this doesn't depend on the dose. Okay. Fifth, we have the nutrition deficiency. We have many types of nutrition deficiency: vitamin A, E, D, C, also B. But the important vitamin types you have to know for your exam. For our exam in the university, we concentrate on vitamin D and vitamin C. Vitamin D acts as an immune regulator. It increases the bone density. That means we have a decreased osteoporosis. Also, it is antibacterial, anti-inflammatory, antimicrobial. Vitamin C maintains collagen, is antioxidant, and it has antihistamine properties, which contributes healthy gingival homeostasis. And what you always read is vitamin C deficiency leads to scurvy. Okay, so you see like the famous legs here, which are bent. These are like, okay, a sign of scurvy. Okay, then sixth, stress and periodontal disease. We have two ways. This is really important. We have two ways that leads to periodontal diseases. We have the direct type of stress through the psychosomatic disorders, and we have the indirect type through behavioral changes that leads to periodontal diseases. The direct one. So the adrenal medulla releases adrenaline, and the adrenal cortex releases cortisol. Okay. Cortisol leads to decreased neutrophils and monocytes, increased inflammatory mediators, and a suppression of IgG and IgA. Okay, adrenaline leads to vasoconstriction of blood vessels and impaired wound healing. Indirectly through behavioral changes, we neglect our oral hygiene, we change our dietary intake, which leads to necrotizing ulcerative gingivitis, and oral habits such as bruxism, cleansing, tongue thrusts, and so on. Okay, so this is really important. The cortisol decreases neutrophils and monocytes, increases inflammatory mediators, suppresses the IgG and IgA. Adrenaline leads to vasoconstriction and impairs the wound healing. Okay, smoking. Smoking is really important. We have unfortunately a lot of smokers. The smokers do have a different picture of periodontitis. So there are 5 points you have to look at: the microbiota composition, the healing capacity, the tobacco smoking, the periodontal tissues, the immune response, and the outcome of periodontal therapy. So the microbiota composition is smokers do have a change of oral bacteria from aerobic to anaerobic, as we have a change. Then what we have here is the periodontal tissues. The periodontal tissues, the edema is not seen. Edema is not seen because smoking does vasoconstriction, decreases gingival curvicular fluid, and leads to hypoxia, whereby calculus forms. Okay, immune response. It delays neutrophils and monocytes, and it leads to a more destructive nature. So the neutrophils have now a more destructive nature. It decreases the T helper lymphocytes and increases the matrix metalloproteinase 8 and 9 especially, and decreases the IgG and IgA, which is as here seen in the stress direct IgG and IgA. We also see it in the smoking. So smoking and stress, we see is suppression of IgG and IgA. And we have a delayed healing process. A delayed healing process, the smoking affects the gingival mesenchymal cells and fibroblasts. Okay, age, of course, with the increase of age, we have an increase of local factors, which leads to increase of periodontal diseases. So we have here the next type, it's the influence, it's the opposite type, but this I will explain the next video. Till then, I hope you understood everything. These are the most important points I took in my university. I hope you could I could help you with these points, and if you have any questions, please write it down in the comments. I will be glad to answer you. Thank you.